Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey, welcome. This is I can't even, what the heck are we calling this thing now? Crap. I almost said this is the Skinny Medic Podcast, but I was like, no, that's not it. So this is the Civilian Medical Podcast, and we're on episode 5. I am Skinny Medic. This is my co-host, Sean Heron. And this episode, we are not going to talk about the RATS tourniquet.
Wait, what? I thought that was...
No. Let's not this week.
Dang it. Okay, fine. I guess I will have to do stuff that I didn't prep for, but that's fine. What are we going to talk about today?
So today we're going to talk about the third phase of care and respiratory, like respiration in the March algorithm.
All right, very nice. Well, I guess first we should refresh everybody and remind them, what are the other two phases of care?
So we had the care under fire, and then we had, we're going to have to edit that part out.
Wait a minute. Should we start over from scratch?
Yeah, let's just start over from scratch. I'm sorry. That's terrible. I was like, oh my gosh, I don't remember.
That's so awesome. I love it. All right, hold on. Hitting record again. I'll play the music and we'll take 2.
Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Hey, this is the Civilian Medical Podcast, and we're on episode 5 now. I'm Skinny Medic, and this is my co-host, Sean Heron. In
Hello.
This episode, we are not going to talk about the RATS tourniquet.
Actually, that's all I had prepared for. Can we, or?
No.
Okay, fine. What are we going to talk about then?
So we are going to talk about the third phase of care. We've kind of been going through those phases of care, and we're going to talk about respiration in the March algorithm.
All right. I love it. So first, let's refresh just a little bit. What are the previous phases of care that we covered?
So we talked about care under fire, and then we did some tactical field care stuff, and now we're going to talk about evacuation care.
All right. That's awesome. So, and just a reminder for care under fire or direct threat, whichever one you go by, that is basically, there's 2 things there: gain the advantage over the threat and consider massive bleeding control as is life-threatening and you are able to do with tourniquets. And then under indirect threat or tactical field care, there's a reduced level of hazard. We watch for reemergence of the original threat and possible other threats, and we do more in-depth interventions based on the March algorithm. And the March algorithm, what does that stand for?
So we have massive bleeding, we have airway, and then we have respiratory, circulation, and then heat loss and head injuries.
Perfect. All right. So when we talk about the tactical evacuation care or evacuation care, whatever you want to call it, just basically getting the heck out of there is the key here. So why don't you tell us just a little bit about what is tactical evacuation care?
So this is moving from where we are currently, the bad situation, towards greater care, like that be EMS or towards the hospital. But we want to get these trauma patients to a trauma surgeon. So this is the process where we start moving them closer to. It doesn't have to be all the way to the hospital, but we start getting them closer to someone who knows more about what's going on than we do.
Yeah, just that next level of care. Because as we mentioned when we talked about legal considerations, kind of once you put your hands on somebody, you're pretty much required to stay there until someone of greater or equal medical experience comes along, unless you would be putting yourself in danger by doing so. So clearly you don't want to spend the rest of your life, helping out that person. So We want to get them to the surgeon, to the hospital, whatever that next level of care is.
Exactly. Even if it's just getting them closer to EMS. I tell my students, we talk about like when you call EMS, like in your mind, you probably think it's going to be skinny medic that shows up. Like you're just had a bad day, skinny medic's going to roll off the ambulance, and that's who's going to be there. And ultimately, I'm not the one coming. It's going to be like this EMT or paramedic who's 6 months on the job, or they're about to get fired. Like that's who you really need to be prepared is going to show up for this call.
Yeah, definitely. So in TCCC and TECC, they talk about lots of drags and carries. This isn't something that I spend a lot of time on because I try to focus more on the civilian person and like, what are we doing? What are the situations that we could possibly be in and how do we kind of escape those situations? But I think that you actually do. So what are some of the drags and carries?
So yeah, in my class, I do talk about it because I'm thinking about like at the office or thinking about the gun range. For me, my range is off the roadway. So if someone got hurt in my range, I'm going to want to bring them closer to the road so EMS doesn't have to hike down to my range. If I'm at the church, then I want to try to bring people closer to the front door to get them to help faster. So I do cover, it's about an hour or so a class. We talk about drags and carries, and it's just that idea that we can move patients closer to help. So one of the first things we always talk about is the carries, like the drunk college kid carry, where two your buddies sit on either side of you, your arm goes across their shoulders, and then you can drag them that way. There's a picture of Virginia Tech shooting where they're coming down this grassy knoll, and there's 4 cops carrying this kid. Like one cop has an arm, the other one's got an arm and his leg, and it's like this kid's all sprawled out like a spider. And I was like, you took 2 people out of the fight there. You took 2 more people than you needed to. I'm like, 2 people could have easily carried this kid. Like if you're doing the drunk carry where he's on your shoulders, one arm on either side. If he passes out, you can still hold him by his belt. You can do him there. So just doing that. I talk about obviously, if we just need to drag someone by their ankles to move them to either some kind of cover or concealment, that we can do that as well. I talk about the halo harness or the hasty harness, which is using a piece of webbing, 1-inch webbing. You make a circle around their body, and then part of it goes up under the armpits, and then you go up under their legs, and it makes a quick harness that you could either lower someone down out of a window, or someone or 2 people can drag them and make a stretcher out of it. And then we talk about like the NAR quick litter, that's something that's pretty affordable that you could put your range like that. It's basically a canvas that has handles, and the one we have is made by Dynarex. It holds like 1,500 pounds, so you've got plenty of ability to carry someone, drag them across carpet, gravel, grass, whatever we need to kind of move them to get to better care.
Yeah, and the key here really is don't cause further injury. That's one of the things we're trying to do. It's one of the reasons they talk about these kind of carries and stuff like that, is because we're trying to get them out of there. We're trying to get them out of there quick, and we're trying to not cause injury to ourselves because we are our own first responder, and also not cause further injury or exacerbate the injuries that they already have, because that would be bad. We're trying to help, not hurt.
Exactly. And this is one of the things too, where my students find out about their cardio, how good a shape they're in. Because now you have a mannequin that weighs 200 pounds, and whether you put your gear on, you're wearing a plate carrier or whatever, or you're just wearing plain street clothes, you start dragging this guy for 50, 60 feet, you're going to get smoked. So it kind of lets my students open up to, all right, maybe we should be walking a little bit every day, even if it's 30 minutes a day exercise, just in case, because your husband may need your help for you to be in better physical shape. So it kind of helps me point that direction too, that maybe we need to take better care of ourselves and take care of our cardio.
Yeah, I feel like you're coming at me right now. No, one of my favorites too is the trunk blanket. A lot of people keep a blanket in their trunk for whatever. You can just lay that on the ground, roll your casualty onto it, and then be able to pull that blanket. Gives you more of a easy way to grip it and keeps them well supported while you're doing it. So definitely lots and lots of options, but use common sense. Like, don't drag somebody downstairs by their ankles and let their head bounce on every stair on the way down. Don't let their head hang back while you're grabbing them by the arms. Make sure that the head's supported and cradled between the arms if you decide that you're going to drag them by the arms. But ultimately, if you are in some kind of direct threat scenario and you're trying to pull them out of a main thoroughfare or get them behind cover or concealment or something like that, do what you have to do. Just it brings me to my next point, which is understand your limitations. Like you were literally just talking about understanding your limitations. If there's a 300-pound dude and you're a 95-pound lady, then are you going to be able to drag that person? Maybe. Are you going to injure yourself? What is it going to take you out of the fight? Is it going to prevent you from helping someone else who might be more critical? So understanding limitations, I think, is a huge part of this, because in the real world, there's a bunch of people and we're all different body shapes, body styles, body types, body sizes. And we have to really take that into account when we're making and formulating our plan, because we're not just going to run out there. We have to have a plan or, tactics that are part of a greater goal.
Exactly.
All right. So we come into a situation and we'll say it's a multi-casualty situation, a multi-casualty scenario. So we come on in and we see multiple things, and then we have to decide who we're going to help first. Who do we put our hands on first? And that is basically called triage. Tell us about it.
Right. So this is one in my classes why I start covering triage areas, because I talk about creating casualty collection points or bringing groups of people together, because you've been treating people, you have a multiple casualty, maybe there are multiple car wrecks and you've got people scattered over a fairly large area. If you start bringing patients closer together, then you don't have to walk as far, you don't have to work as hard. So part of this evac time, I talk about triaging patients, who we can treat first, who needs to go to the hospital first. This is very important because time can save someone's life. So one of the things I encourage my people to talk about is, people with penetrating chest trauma are the first ones who need to go to the hospital. If we put a tourniquet on someone, we have the bleeding control. Yes, they do need to go to the hospital. They need to be seen by a surgeon, but now they have a couple hours time that we can buy them. These patients who have penetrating chest trauma, we can't do anything about that. We're going to talk about that later on in the podcast, what we can do, but ultimately these guys and gals need a surgeon to go in and repair whatever's damaged inside the chest cavity or stomach area. So, I tell my students, if you do have some of those patients, put them closer to the door. That way when EMS comes in, they're going to be the first ones to go out the door and hopefully get seen at the hospital first. One of the things we talk about that makes it easy for triage patients is the 30 can do 2. So if you look at their respiratory rate, and it needs to be under 30, the pulse, the capillary refill, which means you push on their finger, the color should come back to their skin within 2 seconds. And can do means can they follow simple directions. So we typically, as EMS, we divide these patients up into colors. Green tags being someone who can walk. So it doesn't really matter what's wrong with them. As long as they walk, they're fine. If they're walking, then they probably don't need you as the first responder.
Yeah.
Then you have patients, yellow and red tags. Yellow meaning that they're injured, but they can't walk. And then we have the red patients, and these are patients who can't walk. They're going to be more serious conditions, meaning they have probably something wrong with their airway, breathing, and circulation that we can fix. You guys can fix all of what we've been talking about on this podcast. And then we have the black tags, and black tags are dead. And there's nothing we can do about it. In this kind of situation where we have multiple patients, we don't do CPR on them. It's doing you no good to do CPR on someone when you have 4 other people who really need your help, whether that be a problem with their airway, breathing, or circulation, that you can fix. So we kind of have to step over them to help the people that we can help, to do the most for the greater good.
Yeah, for sure. And dead, critical, emergent, and walking wounded. That's exactly what I talk about as well. And I mean that's pretty standard triage stuff right there. And we have to decide. So kind of when you come into a scene, especially with mass casualties or multiple casualties, we'll say, you have to take that brief holistic look. You have to kind of just really make some assessments, mechanism of injury, like where can you see blood, who seems to be in the greatest distress, who can you actually help with the supplies and the knowledge that you possess. These are really quick things that we kind of have to do as we look holistically over the entire scene. And then we have to start taking action and kind of move in. This isn't like sit there for 10 minutes or 5 seconds. It's literally just look around real quick, take a couple seconds, and then get busy. And we make these generalities and these assessments. And then once we decide who we're going to work with, we prove those out. If you get down and you're like, oh, okay, well, this is not what I thought it was. They're either more critical or less critical. If it's less critical, you can move to the next person. And, if you have a partner and you're working with a partner, you guys can talk back and forth. One of the things that I see most when we do scenarios in classes is that people they will become an island, and that island is totally closed off to the outside world. They have no treaties, no trade treaties with other islands. They sit there, they do their thing. They become so extremely task focused and casualty focused that they don't pay attention to anything else that's going on around them. And I love what you said about these casualty collection points. Excuse me, because it really helps get out of that. If you can bring a few people, if you've got 4 people and they're randomly around a room and you run over to one side of the room and your partner runs over to the other side of the room and you guys are not talking to each other, you have your backs turned to each other, and it makes it extremely difficult to actually work together. But if you're able to, get that person to walk over to sit next to your partner and get all these people kind of in the same neck of the woods, not only can you share supplies, but you can get help, you can get a hand if you need it. It just makes everything more simple. And it's so interesting to see just the island that people come when they become so task focused and they have audio and auditory exclusion going on, right?
Exactly. That's what we, perfect example you said was, we can share supplies. So if we can bring them together, then you may have some supplies, I may have supplies, but we can kind of share and communicate and see what's going on. So one of the things when we talk about triage, I always, if I'm going to come into a room that has multiple casualties, or I'm on a wreck that has multiple casualties, people injured, I always say, hey, look, if you can hear me, start walking my way. If you can hear the sound of my voice, I need you to get up and move. So those patients will automatically get up and move. And then I can kind of put them in a little group. I'm like, hey, you see that big tree right there? Go stand by that big tree. Or see that red truck there? I need you to go stand by that red truck. And then I have patients who are not moving, who's, maybe they're screaming their head off, but, they can't get to me. So I will usually say, hey, look, if you can hear me and you understand what's going on, raise 2 fingers up. So now I have victims who are laying on the ground or, whatever, not moving, but they can raise 2 fingers up. So that tells me that they're awake and they can at least make some kind of mental decision to hold 2 fingers up. So then I need to find the victims who are not moving, who are not able to raise their hand up, because they're either dead or they're critically injured. And so that's where those are typically your red tags and black tags. So if we can get to those red tags quicker, then we can hopefully save more lives.
Yeah, that definitely makes a lot of sense. I love that. And I love that if you can hear me and understand me, walk over to me, because the self-ambulation, it's huge. And we very often forget it. Maybe you don't need to drag them. Maybe you just need to help them up and give them a little support while they walk over to where they're going. And don't forget that we don't always have to be hands-on with everything. We have to be able to tell someone else how to put a tourniquet on themselves, because maybe there's multiple people. Maybe there's someone more critical, but they're also critical. And you have to make a choice of who you're going to help. But always keep in mind that people can help themselves to a point. Maybe they can, maybe they can't, but I think we should always give it a try.
Exactly. It may take some encouragement. I've been on scenes where, a victim says, oh, my shoulders hurt. Was there anything wrong with your legs? No. I need you to get up. And your friend's going to help you walk over there. You kind of take a little bit of encouragement. You're not being a jerk, but at the same time, your legs are working just fine. Like, you can stand up. All right. I need you to do this. You look around. This is really bad. Like, I need you to get up. And then, like you were saying, like, you can use help. But typically in the past, EMS, we've taught these green tags. We send them as far away as possible. You just go away. You're bothering me, and I'll get to you eventually. But now we're saying, like, yes, I want to use those green tags. I want to use that person to help me hold pressure, help me put a tourniquet on, or even maybe it's just help hold someone to their side while they're, in the recovery position. So absolutely use these green tags to help yourself. And I always say the joke in my class. I'm like, you're going to have that 19-year-old girl who has a hangnail, and like there's people dying around you, and she's going to be screaming her head off about her hangnail. I'm like, use her. Like, take that 19-year-old little girl and tell her to hold pressure right here. Now, you've made a makeshift tourniquet. I want you to make sure it's going to keep bleeding again. You're going to take that 19-year-old little girl who would have said, oh, she has PTSD, she was in this traumatic event. You're going to make her a hero, and she's going to come out of this, and she's going to talk to the news media and go, I was a hero. I saved these guys' life. I did this with a tourniquet. I held pressure. And I'm like, that's fine. Make her a hero, but make her help you and do some work.
Yeah, I love those kind of distractions. It's one of my favorite teaching tools in the scenarios. Is I find the person who I think is the most loud and boisterous, and I make them the foil. And I'm like, hey, your job in this is you've got this injury. You're absolutely a green. You're walking wounded. It's nothing more than a cut on your arm or something like that. It's not life-threatening at all. But I want you to make it the most important thing that has happened. And I want you to tell the people who are playing the medic right now that they are doing everything wrong and that they need to focus on you. And it's surprising. Like sometimes you'll get the people who completely ignore them, and that's great. You get other people who are like pushing them away, and it's distracting them and taking away from that. Or you get the people who handle it correctly. But I always love doing that because it adds just so much more adrenaline to the situation and really makes people second guess and question themselves. And it is what they're doing correct. And then we talk about it in the kind of after action after every scenario and, point it out. And it's a really good learning tool, I think.
I do. I love it. Like I love playing that person. I love it. So I love pestering the people, especially, like they're just they're so focused on it. And like I'll start asking them random questions in class. Maybe it's a math question. What's 7 times 7? What's 5 times 6? What's your husband's birthday? What's your wife's birthday? Get them really good because then they freeze and the wife gets mad at them. Just random questions. And I love it.
Yeah, I've had some people play that part so well that one person in Texas actually grabbed the cell phone out of the dude's hand and threw it across a parking lot because he was so good at playing that foil. It was great.
Oh, nice.
Vital signs.
So yeah, for me, like this is the first part where we're really going to be able to sit down and take a good set of vital signs. You've went through the March algorithm, you have fixed all the life-threatening injuries, and now if you have some time to kill, maybe you're waiting on EMS to get there, maybe you're can't quite finish the process. This is a great time to get a set of vital signs. We call them baseline vital signs, where you're just getting that foundation of what their pulse is, what their blood pressure is. And then you can take them every few minutes, depending on how long you're with this patient, every 5-10 minutes, and you're going to help see the trend to see if they're getting further into shock or they're improving or what's going on with that. So it does help, and it helps EMS along. If you can tell me, hey, their pulse was 130, but now it's 100, their blood pressure's 110/70, it kind of helps me, this patient's maybe calming down. Or maybe, look, their blood pressure's dropping, the pulse is high, it kind of tells me they're in shock. Maybe we haven't found the bleeding that we missed some bleeding, or it's in the abdomen, it's in the pelvis, it's in the chest cavity, and what's going on. It really does help. And using a pulse ox, I do encourage that, although they do have their limitations. Someone who's in shock, their hands are cold, things like that, but they can be a good instrument, a good tool for you to have in your tool bag.
Oh yeah, so good. I actually had a student named Jose that came through one of my classes, and this was his wife had an outpatient surgery, and he noticed that later that afternoon that she was exhibiting a lot of signs of shock. And he was able to kind of go, and he started taking those, and he's like, oh, interesting. The pulse is really, really weak and thready at the wrist. And he was like, you know what? I think that there's definitely something going on. It seems like maybe she's got some definite symptoms of blood loss. So he took her in, and she was internally bleeding, and she may have actually died had he not, been on the ball like that. So those things, they're incredibly important. They're incredibly great diagnostic tools. We don't spend a whole lot of time in them in direct threat and indirect threat, but this is definitely the time where we can pay a little bit more attention, make sure that everything is progressing the way we would expect it to, and then react and respond and even further evacuate based on what we find.
Exactly. And this is one of those things, you're taking a blood pressure, using a blood pressure stethoscope, take some practice, take some training, but they're much more accurate than the ones you can buy like CVS, the little automatic ones, things like that. So, and they're pretty reasonably priced. You can find $20-$25, you can find a blood pressure cuff stethoscope, and you can obviously spend more money than that if you want to, but they'll take some practice, and it's good education, good learning to understand what you're looking at.
Mm-hmm. Yeah, definitely. Let's talk about, say we don't know. We have to decide, is the ambulance coming to us, or are we going to the next level of care? Are we going to drive? Is someone else going to drive? Is there a helicopter coming? These are all things that we kind of have to figure out as we go. But what if you are somewhere that the ambulance it's going to take 45 minutes to get there?
Yeah, so this is one of the things we talk about. It's kind of controversial. As a paramedic, I have to tell you to call 911. Kind of have to tell you that, but at the same time, I'm like, maybe we should use some common sense. That if it is going to take the ambulance 45 minutes, and that you're 15 minutes from the hospital by driving your personal vehicle, or you're driving, someone else's vehicle, then maybe the decision is we put this guy in the back of the truck and we drive fast to the hospital. Of course, we're going to obey all traffic laws and stuff, of course, but, of course. But, maybe we make that decision. We're at one of the ranges we shoot at. The trauma center is a mile away. And I know that EMS is going to stage. Their response time is going to be 20-25 minutes. I'm like, it makes more sense to put this person in a vehicle and drive them to the hospital. So, If you're 45 minutes away from the hospital and you know the EMS is close, then absolutely wait on the ambulance. Wait there. But understand that if you are somewhere and you are at the range and you have a training accident, it doesn't matter what you say on 911 phone call. They're still going to treat it like you shot me. Like if I call them and say, hey, look, Sean accidentally got shot. He was jumping over a berm, acting like a fool, and we shot him like a clay pigeon. It was an accident. They're going to think that I shot you on purpose. They're like, oh, no, Skinny Medic shot Sean on purpose. We're going to send the police out there. We're going to stage and all this stuff, hoopla, and then EMS is going to be out there 45 minutes later.
Yeah, and for the record, I too am going to think that you shot me on purpose. just so we're 100% clear here. But yeah, and that's tough because also don't forget that, you know, if you decide that you're going to go, or, you know, the ambulance is on the way and you decide that you need to go now because, you know, of emergent symptoms or something like that does add complexity to an already incredibly complex situation, right?
It does. I mean, when the cops come out, now you've moved the crime scene. They're going to want to secure multiple locations. Like, it's going to be a big deal. But it's one of those things you got to do what's best for the patient. And maybe that is 99.9% of the time sitting there waiting on EMS, but there's always that percentage you're like, I think we should just throw them in the back of a truck and let's go to the hospital.
Yeah. So, and it's, you know, we talk about a lot of gray area on this show, and there really is a lot of gray area. There's things we do, but there, you know, everyone's physiology and every situation is different. There's different variables that kind of add to the complexity and strangeness. So we have to work on that. Excuse me, and really make our best guesses and just make our best decisions based on the information we have.
Right. I mean, even at one of the shoots that we shoot at every year down in Georgia, you know, the EMS there is a volunteer EMS service, and there is a hospital one exit up. So we've talked about it. You know, that would be a decision where, you know, I have a lot of cool equipment there at that shoot that we would stabilize the patient on scene, put them in the back of my truck, and we're going to drive to the hospital because I'm not going to wait on a volunteer EMS service to come out. You know, if I need them for something, yes, we'll wait. But, you know, probably more than likely, I have everything in my truck to take care of business. And then I'm going to drop them off the front door of the hospital. And then we're going to talk to the police afterwards.
Yeah, 100%. And really, it's just, you know, figure out what's best, make the best choices that you possibly can. So in evacuation, if we break it down to everything else, we're going to document, we're going to monitor, and we're going to constantly be reassessing by taking those vitals and making sure that things aren't progressing in a way that we don't visually see. But I think that's just about it. Anything else that you want to add there?
No, I think that's it. And that's kind of where, like, we talk about that March E, we add the E onto it, you know, just to get focused that, hey, you can move, you can get closer to scene. So like in my class, when we harp on the March algorithm, but at the end of the day, I'm like, hey, all right, we've been talking about March all day. We're going to add an E to it. And so it's just a little extra thing just to help people remember you can move and get closer to care.
Yeah, 100%. All right. Well, I guess that brings us to the next letter in the algorithm, which is R, which stands for respiration or respiratory. I say respiration because I have a huge ego, and respiration ends in Sean, respiration, you know, stuff like that. So, but yeah, respiratory. Once we make the airway, once we make sure the airway is open, we actually have to make sure that we're using the airway. So why don't you kind of lay us down a little bit of an explanation on what respiration means?
Yeah, so this is like the chest cavity, the chest area, even kind of the abdominal area. You know, I kind of move it that way because who's to say that you didn't get shot with a 22 in the belly and it bounces around to God knows where and it goes through the diaphragm? Like, you can still get some respiratory, some breathing effects to a gunshot to the abdomen. So we kind of, you know, think about this as being a box. You know, we have the arms and the legs, and then you have the box. So this is where we're going to concentrate for the rest of the podcast. Is we're going to be in the box.
Definitely. All right. So once we make sure that massive bleeding and airway have been addressed, we kind of move on to respiration. We pay attention to that box and make sure that we know what's kind of going on there. So first off, what are some of the things that you can actually that respiratory issues cause? Like, what does a respiratory issue even mean?
So you can have someone who is short of breath, means they can't speak in full sentences. And we can even put them in shock. I mean, there's maybe that's compressing on the heart, there's pressure building up, put them in cardiogenic shock. We can have a tension pneumothorax, which means that the lung is collapsing, or maybe there's blood, a hemothorax, which is blood filling up. We have air or blood basically filling up in the chest cavity, and that's pushing onto the heart, pushing onto the major vessels inside the chest area, and that can lower their blood pressure, speed their heart rate up, and we can put them in irreversible shock just by having too much air in the wrong place or blood in the wrong place inside the chest cavity. And unfortunately, there's not much we can do for it as civilian responders. I mean, we just basically have to seal it up and you let God take care of it.
Yeah, 100%. So pneumothorax is basically collapsed lung, but that can be caused from blunt force trauma. It can be caused from disease, chronic disease, drugs, like altered mental status kind of stuff where they just go into some kind of arrest. And then we've got the tension pneumothorax, which is that penetrating trauma that you mentioned. And like you said, there is something that we can actually do about that. So generally, I say if you see a hole in the chest, that we're going to instantly seal it. And chest seals, there's a lot of them. What are some different chest seals, and what are the different types that we might get into, such as vented and non-vented?
So yeah, there's a wide range of chest seals on the market. If you look on just about every ambulance in America, you're going to find the Petroleum Gauze, which is a silver packaging. It's used for burns a lot, but we basically open up the packaging, we throw away the gauze, and we tape it. We're now teaching tape it on 3 sides. The way it'll vent, but that Petroleum Gauze costs less than $1 a piece. So those are very affordable to put on the ambulance, especially for EMS services. You have a bunch of ambulance, things like that. But you can go up above that, which would be like a commercial grade chest seal. And for me, I like the hyphens. The halos are another good one. H&H has a couple of good chest seals, but they're just, the commercial ones are better because they're super sticky. I mean, they're going to rip the chest hair right off of you if you go to peel it back off.
Yeah.
So you can get into non-vented and vented. Vented chest seals are now what most people are going to. Allows the pressure, once it gets built up into the chest cavity, to have somewhere to go to release. So whether it has channels, it has cups, or whatever, however it's supposed to vent, it vents. But most of the commercial ones are more expensive, but you're going to find they're a lot better than trying to improvise to make one. Because if you start trying to put tape on someone's chest, especially if they're diaphoretic because they're in shock and they're sweating, the tape just really doesn't stick too well. So the commercial grades are better in that situation, but they are more expensive. So it kind of depends on your budget.
Yeah, and a lot of people. So I think the vented, non-vented creates a lot of confusion in the marketplace, just especially for people who are like, I know I need this. I may or may not have taken a class, but generally there's voids in the adhesive. So when you put it on someone's skin, there's like a part of the chest seal that doesn't stick. And if you think about the actual act of respiration, when you breathe in, your lungs expand, which would push any air in the pleural space out of that penetrating trauma entry wound, whatever it happens to be. So if you think about that pushes up on that place that has the void in the adhesive, and then that air comes out of there. So that's on the inhalation. On the exhalation, the lungs shrink, which causes that vacuum in there, which would cause air to go in there. But because it has that void in the material, that just kind of gets sucked down over the top of it and doesn't allow more air in there, and lets everything equalize, normalize, and just get kind of back to normal, which is pretty great. You can vent your own regular halo seals or anything else like that, as long as you understand how the lungs work and what the actual mechanism is, right?
Right. That's what I tell, if you have non-vented chest seals, there's nothing wrong with that. Just if you had a patient that was doing okay, and now they're like, I can't breathe, I'm getting more short of breath, like they're getting worse, you probably need to pull that non-vented chest seal off their chest and let it vent. So when they take a deep breath, we want to make sure it's sealed, but then when they release it back, we open it up, and that's going to allow the air to come back out of the chest seal and let it vent itself. Let them do that a few times and then seal it right back up. And one of the things we talk about in class and people don't realize is that how that actually, you were doing a great demonstration on how the lungs, but it's the diaphragm. The diaphragm drops down. It's the muscle that controls all the rest. The lungs themselves don't squeeze and contract on their own. It's the diaphragm which drops down. So if you do get someone who's got penetrating trauma to the diaphragm, or they've injured the diaphragm, they're going to be in serious trouble, because that's their function to breathe. So it's drawing down, it's doing a pressure change, and that's what draws the air into our lungs. And then when it moves up, it makes the lungs smaller, and that's going to change the pressure outside. So that's how it functions basically.
All right, good stuff. Why can't I just take a bunch of gauze and shove it in the hole and just basically fix everything, right?
Yes, I don't think I carry enough gauze to do that in my truck, and I carry a lot of crap in my truck, and I don't think I have enough gauze for that. So when we talked about wound packing in the first couple episodes, we talked about that, and we said, we're going to wound pack the muscle cavity, and that's what you're finding the wound. There's a muscle cavity there that has a hole in it. We're wound packing it. So you're putting that. Using the muscle cavity, you're pushing the artery against the bone, and that's how you're stopping the blood flow.
Mhm.
But in the chest cavity, there is no muscle cavity. Like, it's all open, it's all squishy and moves around. So you can't just put a roll of combat gauze in there. It's just going to float around inside the chest cavity and do absolutely no good. You do have some large vessels, obviously, that are running through there. So if you do get something's injured, you can't pin that against the spinal column and start wound packing. It just doesn't work. So, like you said earlier, we put a chest seal on it, and you get them to the hospital as quickly as possible.
Yeah. And if you're trying to fill like that pleural space where the lungs live with gauze, you're going to create like a gauze pneumothorax, which you definitely don't want to do. Plus, again, like you said, you'd be able to fit all the gauze in the universe in there before you ever did anything.
Exactly. If you start pushing stuff down in there, you're just going to push on the lungs. It's not going to be able to expand, and you're going to start pushing onto the heart, and the heart gets really pissy when you start pushing on it. So there's a lot of stuff that can go wrong. So don't stick your finger in there.
Yeah, 100%. And I always say belly button to collarbone and 360 degrees around the torso, but you actually even use you expand that area just a little bit more.
Yes, we say neck to nuts.
Right.
Anywhere from your neck to nuts, you seal it up. If you've got a hole anywhere, just go and put a chest seal on it and you're fine. Now, if you've got intestines hanging out, yes, you need a pressure bandage. Don't poke the intestines back in. But a pressure bandage around those will hold them in place. They're going to cut them off anyway. But if you've got just a hole on the back or anywhere, and then speaking of that, make sure you log roll these patients, because people do forget that you have entrance and exit wounds. So, because you see a hole in the chest up around the nipple line, don't expect it to be on the opposite side in the same spot. It may be 4 inches lower. It may be moved around wherever. Things, once they get inside, they tumble and they can cause a mess. So always look for that secondary exit wound, things like that, and we'll put a chest seal on it. But yeah, we say neck to nuts. If it's got a hole in it, seal it up there.
Makes a lot of sense. And don't forget, chest seals come in twos, like he said, for a reason. Use them both. But don't forget, he already alluded to it. You can use just about anything as a chest seal. Really, you're just trying to get that hole plugged so that it doesn't disrupt the vacuum that needs to exist inside there. And
right. A gloved hand could make a temporary chest seal. Air is going to take the path of least resistance. And if the hole is greater than 2/3 of the trachea, which is the throat, then that's going to cause that sucking chest wound. So a little small hole in the chest probably is less likely to end up being a true sucking chest wound. But if it is a large hole, then air is going to take that path of least resistance, meaning it's going to go in and out of that hole in the chest now, instead of going in and out the top of the throat where it's supposed to, where it gets oxygen.
Yeah. And this is another time when we talk about, if they're trying to sit up, if they're trying to adopt a comfortable sitting position, we're mostly going to let them, unless we have fear that they have spinal injury. And then, again, we have those tough decisions to make.
Exactly.
When we talk about respiration, typical respiratory rate, the amount of breaths that a healthy adult takes, is usually 12 to 20. You said earlier, under 30 is kind of where we want to be. And that's generally pretty good. I recommend, if you're listening to the podcast, just take a minute and, set a timer for 60 seconds and count how many breaths you take in and out. And surprisingly, 12 seems like a little, but 12, 15, that's generally what we see in classes. And that's kind of where we want to be, because anything outside those parameters, and we can make logical leaps and kind of figure out where things might be going wrong, right?
If you're an EMS and you're listening to this podcast, everybody breathes 16 times a minute. It's kind of a joke for EMS. Like we're like, all right, we're doing our documentation. We're like, oh, patient's breathing 16 times a minute, and we never really count them. But if you are going to count them, don't tell the patient, I'm going to count your respiratory rate for the next 15 seconds.
Okay.
Because they will instantly hold their breath, or they speed up, or whatever. So, maybe you're checking their pulse and you glance over, and don't stare at their chest either, because then you're going to get punched in the face.
Right.
So maybe you watch their belly. Like, you got to figure out a method to your madness here, but don't tell them that you're going to count the respiratory rate, and don't stare at their chest for 30 seconds either. You're going to get in trouble.
Definitely. And the three ways that you can really measure is the awkward one where you just stare at their chest. And basically you're looking for equal rise and fall of both sides of the chest. If one side is rising a lot and the other side's kind of like stagnant or something, well, that might be a key indicator to tell you that something is wrong there. You could listen to their nose, especially if they're unconscious. Just go down and listen and see how many times they're breathing. Or you could even feel, and top of the chest, stomach. You're just really feeling to make sure that the lungs are expanding and contracting, and that things are working as they should. And if they're not, then we're going to look for the reason why they're not, and that's where we kind of find maybe the hole, the penetrating trauma, whatever it happens to be. That gives us a key. So just knowing what the average and the common values are, it kind of helps us decide what to do. But like Skinny Medic said, don't be creepy. I think that's the key. What does progressive respiratory distress look like?
So this is going to be where they're talking in short bursts of sentences. They're not talking as fast as you and I talk. They're saying and they're really struggling to breathe. 1 to 2 word burst that they just can't get it out. Maybe they are sitting in that what we call a tripod position where they're leaning forward. Their arms are on their knees. They're trying to get forward. Make that chest as big as they can get it. Maybe you see muscles around their neck start to pull real heavy, using those accessory muscles. Little bitty small kids will use their nose. You see like the nose flaring, stuff like that. But that's the easiest way is to talk to them. Are they able to speak in complete sentences, or are they not able to speak in complete sentences? Maybe sometimes they get blue around their fingernails, their nose, ears, mouth. We call it cyanosis. They get blue around there. But kind of using some good exam to see what's going on. There again, a pulse ox would be able to help us out too. As long as their O2 saturation is above 94%, we're okay there. But kind of looking and using all the tools in our toolbox to evaluate what's going on. Using a stethoscope to listen to lung sounds. That can be kind of tricky as well. Maybe we hear air, maybe we don't hear air coming out. We hear some funky noises. We don't know what's going on. But we have multiple tools in the toolbox we can look at.
Yep, definitely. And eventually, once they kind of get really emergent, they can have tracheal displacement towards the normal side. So if you kind of see that trachea like bending off to one side, they really need help really fast.
Yeah, I've only seen that one time, and the patient died. That we were late getting 2 of them. There was a vehicle extrication, and I could look and see in there, and you could see the trachea was off to one side, and it was the creepiest thing I've ever seen. And that patient did not make it, just so we couldn't get him out quick enough to extrication. But yeah, it's a late sign. You're correct, and it's really creepy if you ever see it.
Dang. All right, so we've talked about the chest seals and kind of what we can do. And again, as far as chest seals go, like I think Fox seal was one that you didn't mention. As far as they go, like they're kind of pretty much very, very, very similar, right? They work in heat, they work in cold, they work on mud, blood, whatever. Just wipe it off, stick it down, and press it. Do you have a preferred one that you use?
I like the hyphens. I've used the halos as well. So those are probably 2 of the ones that I would recommend people look at. Like I said, the Fox chest seals is another good one. I've never had the opportunity to use them, but they're all pretty much the same, and they're all super sticky. Like you said, they're going to work well in the summertime. They're going to work well in the wintertime. They're all going to hold up pretty much the same.
Yeah. Now there is another option. But I would say probably not for civilians. That we do have a needle thoracostomy or the decompression. What do you think about that?
Yeah, I thought it was well enough that we probably should bring it up, just at least to give the listeners an idea of what it is, but I would not recommend it. I mean, this is one of those things where you're definitely stepping well away from what's going to protect you under the law if you start sticking a needle in someone's chest. But basically, this is maybe they had blunt force trauma to the chest, and there's a collapsed lung, there's air building up inside the chest cavity, or there's blood, and there's no way for it to release. Then EMS can take a needle. It's a 3 1/4 inch needle. It's 14 gauge. It's huge, and we stab it in their chest, usually between the 2nd and 3rd ribs. Maybe it's the 5th and 6th ribs, depending on where you're looking at. But we do that just to give them like a pressure valve, a release that comes out, and it's not a huge deal. I mean, military men and women 18 years old are doing it all the time right now, but it's if you miss is the problem. If you miss it, you're going to stab it in someone's heart. You're going to miss it, stab it in someone's throat, whatever. So that definitely is above that Good Samaritan law. But we have students who ask us all the time about it, and so we show it in class. We give them the landmarks. We basically tell our students, I would not encourage you to do this because it's going to put you outside that legal area that I think you want to be playing in. Unless it's your brother, your sister, your husband, your wife, then that's your decision to make. But typically we do tell them I would not do this, and that's where either having the vented chest seals or knowing how to vent the chest seal, you can delay this being needed to happen. Getting that chest seal in there quick enough is going to slow down this air getting drawn into the chest or the blood building up. It's going to slow that down, but they probably will need this. And even that, doing a full decompression is a temporary fix. They still need a chest tube, which is huge, and it goes in right up on the armpit. They stick it in, and it relieves the pressure, and they need surgery. But that chest tube is what they ultimately need. So they're, again, still moving to that definitive care to get them to help.
Yeah, you mentioned between the second and third intercostal space, but make sure also outside the mid-clavicular line. So meaning that middle, outside the nipple, basically, is kind of where you want to be with that, just to stay the hell away from the heart as best you possibly can. And then that needle actually has a catheter on it, which is basically just a plastic hose, which goes inside there. So once you pop that through, then the needle actually comes out. So the catheter that's what stays in and actually vents that air out.
Right. And so like you said perfectly, if you're dealing with healthy men and women, then you can look at the nipple line, you draw a cross on it, and as long as you say to the upper side of the nipple, you're good. Upper top, either right or left, depending which side of the body you're looking at. But if you draw a cross on it, stay those sides, unless she's like 80 years old, and then don't stab her in the kneecap. That's not good. But you can look at that. It's not that big of a deal. Usually first time medics do it, they get like all excited, and you're like, okay, that kind of wasn't a big deal, and it's not a huge deal. But understand it's a small catheter. Like, we look at it and it is a big catheter, but what they actually need is super big. That catheter will seal right back up within a matter of a few minutes. So they may need it again, things like that. But just so you have the education and you're aware of what's going on there.
Yeah, and the risks involved. I mean, as a civilian to a stranger, there's no way I would do it. Just don't have the legal protection. And I
would stab you in the chest, but I mean,
yeah, I would literally with a knife, right? Though.
Yes, I like pull out my. I was gonna say Benchmade, but I can't pull out my Benchmade anymore. I get in trouble.
We're not allowed.
But yeah, I'm not allowed to carry my Benchmade anymore. But yeah, I would pull out a knife, like, Sean, I think you have a tension pneumothorax. Hold still. Quit running away from me. Let's do this.
now you actually have one.
Yeah.
That's good. Let's see. I'm trying to think if there's anything else that we have here. We talked about the sucking chest wounds, open pneumothorax, chest seals, and all that stuff. So I guess we come up to a scenario. We see an individual that seems to be having trouble breathing. We can see that there's blood on the front or the back of the shirt. So we come in, we take a second to assess and figure out exactly where all that's coming from, and then we use our chest seals. We put those chest seals on, and once we put the chest seal on, if the respiration doesn't improve and they're still having trouble, there's not much else we can do, right? This is just one of those times where these are the things we can do. These are the actual symptoms. And once we do those things, that's it. We have to get them to the next level of care.
Exactly. Another thing we could, you make a look at, and it's kind of it takes some skill, takes some practice, is using a bag valve mask. You say you have a victim who is not breathing at all, means they still have a pulse, but they're not breathing for whatever reason, with chest injury, which you can absolutely have that. It's called respiratory arrest. Then they need some help ventilating. So you can use a bag valve mask, and this does take some practice, where you put a mask on their face, and you have an external bag that you squeeze, and it forces air from the outside into their lungs. Just enough to get that chest rise. But it takes some practice to be able to get that seal across the face, and to make sure you're not just blowing air out, other places doesn't really affect. So using a bag valve mask is something that we practice a little bit in class, but that's more like CPR kind of class. So we do mention it, but for someone who's breathing less than 8 times a minute, that is not effective breathing. So if we can assist them a little bit, we can buy them some time until first responders get there.
Is there a danger for civilians to use a BVM?
So one of the downside is getting a good seal on the chest. And then if you don't do a proper head tilt chin lift or an airway adjunct like we talked about in the last episode, you can get air into the belly. And then so on the belly starts filling up with air, then all that gastric contents, the beer and pizza or whatever else, is going to come up, and then it goes into the lungs, and you can get pneumonia. So there are some risks to that, but there's some benefit as well. So to look at that. So if you think you have everything, like I got all this stuff taken care of, you don't have a BVM, then I would look at adding that and getting some training, some hands-on training, other than listening to a podcast, watching a video. I think that definitely is one of those skills that needs a hands-on to make sure you can get a good seal and you can get some chest rides out of it.
Exactly. And once again, we're always trying to make things better, not make things worse. And that is one of the things, if you watch a lot of YouTube or whatever and you don't actually go get the actual training, is that there is that kind of danger that you could cause problems like that. So get the training, listen to this, and literally Skinny Medic mentioned tools in your toolbox. Like that's what all this is having better tools, better skills, better everything to make sure that you actually can assist if something bad should happen.
Right.
All right. Anything else on respiratory or respiration?
Not that I can think of.
All right. So we've got tactical field care, care under fire, and tactical evacuation care, or direct threat, indirect threat, and evacuation. And now we've got massive bleeding, airway, respiration, circulation, and heat loss, head injury. That's where we're going. Next episode is to that circulation, and shock is a big deal. And that's kind of what we do in the circulation step of the March algorithm, is assess for shock and understand how shock affects the body and understand how blood loss affects the body. I think that'll be a good one. There's a lot of learning to do there, but it is also one of the ones that we can do the least amount as a civilian, right?
Right. I mean, there's some really cool stuff that they're doing pre-hospital in the military setting for this category, but we're super limited to what we can do as just a regular person trying to do some good.
Yeah, 100%. We'll talk about all that next week. Don't forget to check out Medical Gear Outfitters. There is a coupon code. It's Civilian Medical. It gets you 10% off, and that's medicalgearoutfitters.com. Any final parting words, Skinny Medic?
No, I think it's going good. I thank you guys for the feedback on iTunes. I've been reading those reviews and getting a lot of good positive message on Instagram, stuff like that. You guys are loving the show. So I appreciate all the support.
Definitely check us out on social media. You can find us everywhere, pretty much all the podcast places like Google Podcasts, iTunes, just pretty much everywhere. And keep leaving us reviews. We really appreciate them, because I don't know about Dietrich, but I have a really, really fragile ego. So I need all the good stuff I can get.
Yes, sir.
All right, buddy. We'll talk to you next week. And to everyone listening, thank you so much. We will see you soon.
Find us and subscribe at civmedical.com.